Chapter 12 Observation Schedules, Checklists and Rating Scales. Shuru Bandale. Abstract. Observation schedule is a particularly useful tool to observe and assess performance of students as well as teachers in medical education. This tool can be created or compiled for a specific trait, construct like history taking, physical examination, communication, procedures, preparation, participation, teaching, skills, etc. using structured items and predefined scoring rules. Observation schedule is used as a checklist or rating scale widely in medical education. You must gather evidence of validity and reliability before using observation schedule in the high-stakes setting. The content validity of the observation schedule must be established using iterative discussions and or through consensus indices from the content experts. Pre-test is used to gather evidence of face validity using debriefing with the volunteers and observers, whereas pilot test is used to gather the evidence of internal consistency reliability using alpha coefficient. And inter-rater and test-retest reliabilities using linear, non-linear correlation coefficients. The what-if analysis of alpha coefficient should be used to establish tentative construct validity of the tool, but factor analysis must be done to confirm it. G-theory-based decision studies can also be done with well-planned pilot studies to find number of items, observers, stations, sessions, encounters required to achieve minimum level of generalizability. Quality assurance of the observation schedule tool in terms of difficulty level, discrimination level, fairness, etc. is done using classical item analysis and item response theory methods. The mean, standard deviation, or median interquartile range is used to summarize the bell-shaped and skewed item total scores respectively. Similarly, parametric tests are used to compare scores following normal distribution, whereas non-parametric tests are used to compare skewed scores. Keywords: observation schedule, checklist, rating scale, validity, reliability, construction, analysis. Assess need. Observation schedule is made up of observation and schedule. Observation is the process in which individuals observe the events in a predefined situation and record them according to a prior plan. So, you need to plan, execute, record, and interpret the scores with justification for various levels of observations. Schedule, on the other hand, is a tool consisting of a set of questions asked and or filled by one or more individuals. So, observation schedule is a bit different from a questionnaire as it contains a focused list of structured items to collect information of an underlying trait using a specified scoring rule in a short form. A checklist is a simple tool consisting of parallel lists of items which are constructed or compiled by an individual or group of individuals relevant to the construct or trait under consideration. Here each item is measured on a binary scale which draws attention of the observer to the items and enables her to record the data quickly and systematically. Thus, checklist responses are a record of the observed facts rather than the judgments. Checklist can be of four forms, but observation schedule checklist uses the form where all the items are given in a list, and the observer is asked to check in all the items found in a situation with done, not done, yes, no, etc. Rating, on the other hand, is used to express judgment regarding the situations, objects, and persons, and the judgments are usually expressed on a scale. It can be observed and recorded using numerical, graphic, standard, forced choice, and cumulative point scales. Numerical rating scale, e.g., 1 unacceptable, 2 needs improvement, 3 good, 4 very good, 5 excellent is commonly used to score the attributes related to a trait, construct during observation in medical education. This means rating scale provides the opportunity to the observers to use his or own judgment on the items included in the observation schedule like objective, structured, clinical, practical examination. However, you need to train the observers if you need objective, valid and reliable scores from an observation schedule based on numerical rating scales, e.g., mini-clinical evaluation exercise and direct observation of procedural skills. Thus, it is necessary to decide a priori about the scoring methods for the observation schedule to use it as a checklist or rating scale in medical education. Once you compile the items and decided on the scoring method for the observation schedule, then it requires evidence of validity, e.g., face validity from pretests, content validity with expert consensus, and construct validity with factor analysis. It also requires evidence of internal consistency, inter-observer, and test-retest reliabilities. G theory can be used to determine the number of items, observers, and counters to achieve minimum level of generalizability. You can use appropriate descriptive statistics to summarize and suitable inferential statistical methods to compare item scale score with sex, age, observers, etc. in medical education. Brief observation schedules are useful to observe the performance of students as well as teachers using checklists or rating scales in medical education. Observation schedule contains focused and structured items that are used to observe certain traits, construct under consideration using certain scoring rules. You must gather evidence of reliability and validity for a new observation schedule developed in the local setting and the observation schedules developed in the other settings before using the local setting. Classical test item analysis is used to assess the quality of the observation schedule scores, and descriptive statistics helps to summarize them. Item response theory is used to evaluate the fairness of the observed item. Scale score with age, sex, and other important background variables. Inferential statistics helps to compare item scale scores with important predictors. CO and 3XTUA arise in E. Scenario 1. You are the coordinator of the medical education unit committee. You decided to evaluate the didactic sessions of the faculty using an observation schedule to provide feedback and improve the didactic teaching learning sessions. You decided to compile a new observation tool and validate it a priori, evaluated by at least 2 faculty in each session. The committee members compiled various observation schedules currently in use for this purpose. You now need to gather evidence of validity and reliability of this tool so that it can be used effectively in your college. Scenario 2. You are the problem-based learning coordinator of your college and plan to introduce a process assessment tool to assess the soft skills of the students in the PBL tutorial sessions. You have decided to compile a new tool from a literature review, validate it, and use for formative as well as summative assessment of affective domain in your college. You also plan to develop, validate, and use student assessment of tutors to assess facilitation skills of the PBL tutors and use it for formative purpose. Scenario 3. You are the clinical year coordinator of a medical college implementing a new competency-based medical curriculum. You need to use OSPE, OSCE with observation schedules to assess non-certifiable competencies and mini-CEX, DOPS to certify competencies. You have decided to conduct a half-day, full-day workshop to write OSPE, OSCE stations with at least 2 faculty members from each department to establish face and content validity of these stations. You also decided to convene a separate workshop to write rubrics for the pre-validated mini-CEX, DOPS rating scales to use them effectively in your college as you found problems using these tools without the benchmarking. Describe purpose. You can use an observation schedule as checklists or rating scales to assess online and offline classroom teaching skills of faculty for formative as well as summative purpose. Similarly, you can use them to assess the performance of the students for formative as well as summative purpose. You can also use observation schedules to assess the performance of the students in the small group tutorials, clinical club checks, community postings, etc., and use them for formative as well as summative purpose in medical education. Advantages and disadvantages. Observation schedule is a very useful tool based on focused and structured list of items related to a particular construct. This tool with binary scale scoring is used widely to conduct formative and summative assessment in undergraduate levels due to its scoring simplicity, whereas observation schedule with rating scale is common in the formative and summative assessment of postgraduate levels due to its scoring complexity. Observation schedule requires at least one trained observer for each encounter, and this presents a logistic problem in many situations. Further, it cannot be used for the constructs that do not require observation, such as interpretation skills. Observation schedule with binary scale scoring is prone to measurement errors as the candidates can fake it. Guess the items included in the tool, whereas observation schedule with numerical rating scale scoring without rubrics can produce a biased score if the observers are not experienced and or trained personnel. When to use, you must use observation schedules as checklists or rating scale when you need to get objective, defendable, and generalizable score of a particular construct. Treat those structured item and scoring system. This can be a high-stakes situation like selection of students using admission OSCEs or low-stakes situation like providing feedback to students after a TBL tutorial session and to the faculty after a large group session. You can also use this tool for getting objective, valid, and reliable scores of applicants. Students on the history taking, physical examination, communication, counseling, procedural skills, etc. that require direct observation. This can be a single or multiple in vitro OSCE stations and mini-CEX or DOPS tools with single or multiple in vivo encounters. Construction. You can construct the observation schedule from scratch using focus group discussions with experts or compile it using various published and unpublished sources. You can ask a single or multiple person to compile, construct it, but validity requires process documentation of discussions and content validity indices. So you will face difficulty to establish face and content validity of the tool constructed by a single person. Iterative discussions among the content experts must be done to ensure content validity. Once the observation schedule is tentatively agreed by the content experts, then you must do a pre-test with 5 minutes 10 volunteers involving other experts as the observers. This must be followed by debriefing with the volunteers and experts involved in the pre-test to establish the face validity of the tool. This process must be properly documented and analyzed using qualitative data analysis methods like content thematic analysis. Pre-test results must be discussed among the same group of content experts and modified for the pilot test in consensus. And once the revised tool is available for the pilot study, then it must be pilot tested with a large number of candidates to compute the internal consistency reliability. Inter-observer reliability, test-retest reliability to gather evidence of the tool reliability, and generalizability coefficient to gather evidence for its generalizability. Administration. Administration of observation schedule is different for pre-tests, pilot tests, and final administration. Observation schedule can be delegated to individual level for the diagnostic assessment, as validation of the tool is optional, whereas observation schedule should be delegated to a group concerned department for formative assessment, as tool validation is desirable here. The observation schedule must be done at the central experts level for summative assessment, as pre-validated tools must be used for this type of assessment in medical education. Thus, you must promote the micro-teaching session in the faculty development workshops and follow it up systematically if you are planned to evaluate teaching skills of the faculty using observation schedule. You must use a valid process assessment tool like tutor assessment of student to longitudinally monitor and evaluate the effective domain of students in small group tutorials. You can also utilize self-assessment of student and peer assessment of student to validate the task tool scores obtained from the same sessions as shown in Figure 1. Figure 1 means SAS, PASS and task scores integrated GI block. Basic Sciences MBBS program, Nepal. Analysis and observation schedule as a checklist. Rating scale is analyzed using individual item or the scale scores as unit of analysis. Firstly, the internal consistency reliability of the observation schedule must be obtained as shown in Figure 2. It shows the alpha reliability coefficient of 0.7642 for a 12-item observation schedule with 5-point rating scale from a pilot test with 35 students using the R statistical software. As the reported alpha coefficient is greater than 0.70, you can say that the 12 items are internally consistent to measure of the satisfaction construct. Figure 2, alpha reliability coefficients and what-if analysis of 12-item observation schedule, Nepal. You must extend this result with what-if alpha reliability analysis, where alpha coefficient is assessed by removing one item at a time from the scale as shown in the reliability, deleting each item and turn result in the Figure 2. If the alpha coefficient decreased after removing certain items from the original alpha value, then those items must be retained in the scale. In addition, if alpha coefficient increased after removing a certain item, then those items can be removed from the scale. This also means that Q1, Q2, Q3, Q4, Q5, Q6, Q7, Q10, Q11, and Q12 are related to the construct under consideration, whereas Q8 and Q9 seems to be not related to the construct. However, it requires further what-if analysis by dropping items giving higher alpha reliability after its removal or the items with a low item total correlation i.e. below 0.31 by 1 from the scale. This helps establish tentative construct validity of the tool, but it must be confirmed using the factor analysis techniques. Figure 3, final what-if alpha reliability coefficient of the 12-item observation schedule, Nepal. Figure 3 shows that alpha reliability does not improve further after removing Q8, Q7, and Q9 from the scale. Further, item total correlation is now greater than 0.3 for all the remaining 9 items, so you can accept the training satisfaction scale with the highly internally consistent 9 items now. This was a 12-item observation schedule used to measure satisfaction of the 7-day research methodology and data analysis workshop where Q7, Q8, and Q9 were related to logistics. The trainees gave less importance to these 3 items than others, and what-if alpha analysis traced it well and removed them from the scale. Figure 4, scatter plot of total score of Observer 1 and Observer 2 in an OSPE station, pilot test, India. Secondly, you must assess the inter-observer reliability of the observation schedules using scale. Total score of 2 raters with correlation coefficient as they provide measurement of relationship for 2 continuous variables I. scale total score of Radar 1 and Radar 2. Nonetheless, you must assess the linearity of these scale total scores using a scatter plot. And if they show linear relationship as in figure 4, then you can use Pearson's correlation coefficient. Otherwise, you must use Spearman's rank correlation coefficient as shown in table 1. Thirdly, you must also gather evidence of test-retest reliability for the observation schedules. So, you must do the test and retest of the observation schedules within short period of time, e.g. after a tea snack break, so that you can control the contamination and fatigue among the students and observers. Table 1 Internal consistency, inter-observer and test-retest reliabilities of OSPE stations, pilot tests, India. Table 1 shows the pilot test result of 3 physiology OSPE stations done in India. Blood pressure measurement station shows a good internal consistency. Very good inter-observer as well as test-retest reliabilities, whereas pulse measurement station shows an acceptable internal consistency due to few items included in the observation checklist. Good inter-observer and excellent test-retest reliability. However, vital registration measurement station shows unacceptable internal consistency and iterator reliability, but it shows an excellent test-retest reliability. So, you can accept pulse and blood pressure measurement stations for the summative assessment in such situation. The findings of Table 1 and Figure 5 must be discussed in a team of experts so that you can also apply the contemporary approaches to validity argument using the Keynes framework. Figure 5 Histogram of total OSCE score S-Pest module, Nepal. Figure 5 shows the distribution or total score of students from 13 OSCE stations used to assess structured physical examination skills training module piloted for the early clinical exposure course in a private medical college of Nepal. Distribution of this 13 station OSCE score is tentatively bell shaped, so you can use mean and standard deviation to summarize it and use parametric tests to compare it with gender, age, groups, etc. for its fairness and or discrimination indices. Once the psychometric evaluation of the observation schedule is complete and the observation schedule is deemed valid and reliable, then you can move to the statistical analysis of scale using descriptive and inferential statistics. You can use the mean of the checklist items and weighted mean of the rating scale items to assess the item-wise difficult level and or consensus indices. When you find an outlier, extreme item score, then it must be assessed by gender, age, and other predictor variables, as they will provide you evidence of the fairness or discrimination power of the tool. You can use a special item response theory technique called differential item functioning to conduct this type of analysis, or use common statistical tests such as t-tests. Mann-Whitney median test to compare item score for variables with two categories. You can use one-way NOVA Kruskal-Wallis median test to compare item score for variables with more than two categories depending on the distribution of the item score. Figure 6 box plot of total blood pressure measurement score by two observers, pilot tests, India. The main use of the valid and reliable observation schedule tool is the scale score, as it represents the value of the trait construct. You can summarize the scale score with mean and standard deviation if it is bell-shaped like figure 5, and with median and interquartile range if it is skewed to the right or left. The scale can be assessed using a reference range of mean plus 2 times standard deviation for the bell-shaped distribution, or median plus 1.5 times interquartile range for skewed distribution. You can label the scores beyond this range as outliers, extreme values like student 38 shown with O in figure 6. This comes handy to assess students with poor and good performance, and or the observers with leniency or stringency traits. The other main use of the scale score is to compare it with the socio-demographic and educational variables to confirm or refute the research questions using estimation theory or hypothesis testing approach. For instance, you can test whether the median score between observer 1 and observer 2 in figure 6 is statistically different or not using estimation theory if it is a cross-sectional study, and hypothesis testing if it is a comparative study like non-experimental, quasi-experimental, and experimental designs. Summarize: the observation schedule is a very useful tool to observe and assess the performance of students as well as teachers for formative as well as summative purposes in medical education. This tool can be created or compiled for a specific construct using structured items and predefined scoring rule. It is required to gather evidence of validity and reliability before using it in the high-stakes setting. Quality assurance of the observation schedule tool can be done using classical item analysis and item response theory methods. The mean, standard deviation, or median interquartile range is used to summarize the bell-shaped and skewed item total scores. Similarly, parametric tests are used to compare bell-shaped scores, whereas non-parametric tests are used to compare skewed scores. Evaluate. Imagine that you have decided to use standardized patients in USCE stations in your college to assess the performance of the students using observation schedules. You now need to create multiple parallel OSCE stations, and you need to ask, how am I going to establish the content validity of these parallel OSCE stations? Who will be involved in the compilation of the items and deciding on the scoring rule? You also need to think how to gather evidence of face validity as well as internal consistency, inter-observer and test-retest reliabilities of the parallel OSCEs. Who will be the standardized patients? You also need to think whether you are going to use staff, faculty of the college, hospital, or professional actors as standardized patients. Depending on the local context, you need to decide on using staff, faculty in the summative assessment or not. In both the cases, you need to think about the training of the standardized patient and the observers. You need to pay the standardized patients and may end up paying a huge amount of money as professional actors charge per encounter or per day basis. Thus, some medical colleges enroll standardized patients from the community, train them, and put them in the payroll. Can you do this in your college? During the training, as well as formative and summative assessments, you need to have multiple standardized patients for the assessment of the same construct. So how are you going to organize the trainings of the standardized patients for the particular stations and switch them after certain rounds? Who will be involved in the training and what logistics are needed for it? Also, decide if standardized patients can score the performance of the students on the station or not, and how to control the communication, contamination between standardized patients and students prior to the assessments. Go ahead. Cut-off score of performance assessment with observation schedule checklist or rating scales must be based on the sound standard setting methods. Criterion reference method must be used to determine the pass marks of the performance tests, instead of a fixed criterion of 50% or 60% pass marks widely used. Borderline, borderline regression, or contrasting group methods must be used to standard set the performance tests like OSCE, OSPE, and mini-CEX, BOPS. The criterion reference cutoff score of performance tests with observation schedules, tools like OSCE, OSPE, mini-CEX, and DOPS must be based on the performance on the objective checklist. Rating scale along with the holistic global rating. Comparison of checklists. Checklists with global ratings and rating scales only in the same OSCE stations as described here. This will provide different pass marks than the 50% or 60% pass marks used in the undergraduate and postgraduate medical education in South Asia and considered defendable. Three criterion reference methods have been used widely for the performance-based assessments around the globe. They are contrasting group method, borderline method, and borderline regression method where 2-point, 3-point, and 5-point holistic global rating is used to find the pass mark of the objective checklist. Rating scale score. This paper describes the various criterion reference methods for OSCE. What do you think about these methods? Is this applicable, feasible, and acceptable in our setting? How to include them in our settings?